Good evening, everyone. And I want to thank you all for being with us this night. So we'd like to welcome you all on the 58th MENASO Education Academy Cerebrovascular Grand Round webinar. So this webinar today will be on mobile stroke unit entitled Mobile Stroke Unit Care from the Field Recognition to Global Implementation. This session will highlight a topic of great importance to advanced stroke care, and we are extremely delighted of joining forces with esteemed international speaker to deliver the program combining cutting-edge research, expert insight, and eventually an interactive discussion. Together, our shared goal is to raise standards, enhance clinical practice, and ultimately improve outcomes for patients across the region and beyond. I would like to welcome my co-moderator for this session, Dr. Saeed Zahrani. Saeed?
Thank you very much, Dr. Fahad. Today we will explore mobile stroke units implementation with Dr. Mohammed Shazam Hussein. He is going to present current practice and future directions in mobile stroke units. Dr. Frederick M. Husty will talk about pre-hospital stroke care and critical care transport, integrating MSU into the EMS system. Dr. Zishwan Khawaja will discuss health economics and documentation excellence in MSU deployment. And finally, Dr. Ahmed Al-Khairi will present the Saudi experience during Hajj, launching the mobile stroke unit under unusual circumstances. These are highly relevant topics, and I am sure you will find them both insightful and informative. Please, the question and answer sessions will be after the last lecture. So now it's my pleasure to introduce our first speaker, Dr. Mohammed Shazam Hussein, who will present current practice and future direction in mobile stroke units. Dr. Hussein is the director of Cerebrovascular Center at Cleveland Clinic Neurological Institute. He is a vice chair for safety, quality, and patient experience, and professor of neurology at Cleveland Clinic Lerner College Medicine. He earned his medical degree from the University of Saskatchewan and completed neurology and vascular neurology training at the University of Alberta, followed by endovascular surgical neuroradiology fellowship at Cleveland Clinic. He leads multidisciplinary team covering stroke, neurocritical care, endovascular, and cerebrovascular services, while overseeing safety, quality, caregiver well-being initiative across the institute. His research focuses on endovascular therapies for ischemic stroke and hemorrhagic stroke, with over 200 peer-reviewed publications, a global leader in stroke and neurointervention. He is pioneered advances in mobile stroke unit treatment, and currently serves as the president of the Pre-Hospital Stroke Treatment Organization, Bristol. We welcome you, Dr. Hussein, and the floor is yours.
Thank you so much for the very, very kind introduction. Really appreciate the invitation to be here. I'm going to try to share my screen here. Okay, again, thank you so much for the opportunity to present. An honor to be here. So basically, I'll try to take you through a quick discussion a bit about the evidence behind mobile stroke units, highlighting this importance of the time that it takes to treat stroke patients, a little bit about the concept of the mobile stroke unit, although Dr. Husty is going to expand more upon this, and mainly we're going to spend time talking about the outcomes of things. As we know, people who deal with stroke, though, that the stroke treatment decision is very, very important that we have the CT scan, because even, the best stroke neurologist in the world, Dr. Ajlan, he cannot tell the difference between a ischemic type stroke and a hemorrhagic type stroke until you have the CT scan performed. And you can see here, obviously, the treatment paradigms are very, very different. Those who have ischemic stroke, we talk a lot about, of course, some blood pressure control, but we're mainly trying to understand acute stroke therapies. Are we going to give this patient IV, TPA, and then, how are we going to manage that situation? Versus a hemorrhage situation, obviously a much, much different scenario there, very important for blood pressure control, anticoagulation reversal, and certainly giving a thrombolytic agent to this patient would be very, very dangerous. So very, very important that we distinguish that. And unfortunately, we're still very much hinged on that CT scan. And so I really like this quote from Dr. Michael Hill from many years ago, but it is really recognition that we have to think about this disease process a little bit differently, and that we cannot expect our patient's disease biology to match our systems. Because the time window for treatment is so short, we have to match the systems to the biology. And that's where our colleagues in Germany, first at the University of Saarland and then in Berlin, developed this mobile stroke unit concept. And then we were able to bring that into the United States, ourselves in Houston, being the first centers in the United States to launch mobile stroke programs. And so what these are essentially are ambulances with that CT scanner on board. And it allows you then to be able to take the CT and the stroke expertise right over to the patient. And so from the Berlin team, we saw some really interesting data that emerged from that. This was the first paper on mobile stroke units that was by the Professor Fassbender and the team at the University of Saarland. They were able to do a single week on, week off randomization. And what they were looking at was that primary endpoint was this alarm to therapy decision. How soon could they make a therapy decision on these patients? And then you see here in the red box there, what they saw was that on those mobile stroke unit patients, they were able to get to that decision much, much faster, an average time about 41 minutes in difference. And so just to give everybody a frame of reference here, for every 15 minutes, so we can reduce time to treatment, that's 5% more patients that are walking and 3% more patients that can go to their home environment. So even 15 minutes has a significant impact on patient outcomes. And in this particular case, we got 41 minutes of time savings by taking the CT scanner, the ambulance, the stroke expertise to the patient. Similarly, when we look at in the Berlin experience, the STIMO project, they were able to, again, take a week on, week off randomization. This is Dr. Otterbert and his colleagues, and compare that STIMO deployment versus STIMO weeks versus control weeks. Now, first off, I think it's very, very important to recognize that Germany is a very, very well-organized system, and they have some of the highest TPA utilization rates in the world. You can see here that we're 21% in the control rate. So already their system is at a baseline very, very strong. But take a look at the TPA utilization in the STIMO weeks. That increased the rate of utilization up to 33%. So again, already an excellent system, and we're improving TPA utilization even faster. And if you look at that again, that alarm to treatment decision time point, you can see here that they were able to do it with the STIMO deployment in 51 minutes versus their standard week of 76 minutes. So again, a substantial amount of time savings by using the mobile stroke unit. And so that again led to our development of our mobile stroke program here in Cleveland. And I wanted to quickly show you guys, again, Dr. Houston will get more into the operations and how the mobile stroke unit functions. But I wanted to kind of show you some data that we utilized in our first 100 evaluations. So they're still in our pilot phase very, very early on. We took the first 100 evaluations we did on the mobile stroke unit and then basically analyzed those patients. You can see in those first 100 evaluations, we had probable acute ischemic stroke in 33, possible in 30, TIAs also were at a certain number, and then we had 5 ICHs in that population. And then this other category, we had 28 patients that didn't have presentation as a stroke scenario. Interestingly, though, those 28 patients did have other neurological diagnoses. These were seizures, these could be brain tumors, but other things where you could argue having that early neurological diagnosis could help you with triaging and where to take that patient. Looking at those patients, again, the ones that in the emergency room you would be really considering acute ischemic stroke, that was this probable acute ischemic stroke category, and about 16 of those, so just close to half, were getting IV thrombolysis in that situation. This graph, I think, very, very important. It looks at the time to treatment. So again, we were seeing about what the Berlin data showed us. If you take a look at, again, this alarm to treatment time, and this is also another thing that we're very, very, I think, interested in, is that rather than looking at the door-to-needle time, which is what we traditionally measure in hospitals, let's look at the alarm or the dispatch of an ambulance to when those patients are getting treated. And if you look at that particular metric, if you look at the mobile stroke patients against the control patients here, what you see is that there was a substantial decrease, almost 40 minutes of time saving. Again, remember what 15 minutes does in terms of allowing people to have better quality of return to function and quality of life. We're substantially decreasing the time to treatment in this patient population. I really, really love this graph. This was a paper by one of our fellows back in 2017, where we looked at that pilot phase, again, that first 100 patients that we treated. And you can see that compared against our Cleveland emergency rooms, we certainly did much better than that. But what I'd like to draw your attention to is look at, again, what were considered the best areas in the world for stroke care. Melbourne, Helsinki, places that did the direct to CT. They were treating patients very, very fast. Door to needle times, you can see here, 20 to 25 minutes. If you look at from the onset to treatment time, though, again, trying to understand that at an earlier time point, onset to treatment, we were already on the mobile stroke unit treating faster, 97 minutes, compared to these, again, best programs in the world, just in our pilot phase in the mobile stroke unit. So very, very clearly, I think it establishes that with a mobile stroke unit, you are definitely going to be treating patients faster on a mobile stroke unit than you would in a traditional setting. And of course, we know time is brain, and so that impacts us quite significantly. The other important factor, I think, with mobile stroke units is talking about how we can use these vehicles as triage units. You can see, of course, that these mobile stroke units, essentially, you can think of them as primary stroke centers on wheels. They're able to do all of that acute initial therapy as well as triaging. And so it allows us, so this is an example of a case that of a large vessel occlusion, case-matched analysis where we have a patient that would have been going to a certain hospital. Prior to mobile stroke unit, this patient goes to the primary stroke center, gets their CT scan. We know our EMS colleagues are usually pretty good about getting patients to that first hospital, but getting from hospital A to hospital B can sometimes take a substantial amount of time. So you can see the total amount of time to get to the interventional therapy. Look at here now with the mobile stroke treatment unit. You can see here again, mobile stroke is now providing that primary stroke center function, delivering the IV thrombolysis, and then we can directly take that patient to the center that does the thrombectomy. You can see here in terms of time savings, that's about 3 hours of time saving that we're providing in that patient population. This is in keeping with our Berlin colleagues. They were able to show that they had reduced transfers to non-stroke centers, as well as had more ICHs, or I should say less ICHs going to non-neurosurgical centers, more of those ICHs ending up in hospitals that can handle that level of care. I had mentioned about the ICH population. We did see 5 ICHs in that early time period. And this is, in 2015, Dr. Gomez from our team was able to publish the first field anticoagulation reversal in a case of ICH. We were able to take a patient with, intracerebral hemorrhage, give them that at that time we were using 4-factor PCC in the field. They had an INR of 3.2 on the mobile stroke unit. By the time they arrived in the neuro ICU, their INR had normalized. Obviously, it's just one case. You don't want to go overextend and make too many interpretations of that. But really, again, I think we recognize how important that early anticoagulation reversal is, and this is a good evidence of how effective that can be. Now, moving a little bit more, again, the first question is, can we treat patients faster? Again, I think we've established that. There was now then further studies that looked at, well, if we treat these patients faster, is that going to improve the patient's outcome? Given the link between time and outcome, I think we're very confident of that. But there were 2 important studies that were done that helped to establish this as improvement in outcome. That's the Be Proud trial in Berlin, where they again expanded their mobile stroke unit fleet that they have there. And you can see here by the map of Berlin, they had kind of these units stationed kind of in different locations around the city that allowed them to be able to cover the periphery, but also had multiple units that were able to cover the dentist area of that patient population. Again, similarly, though, they again randomized basically the mobile stroke units to weeks when it was available versus weeks that it's not available. You can see here very, very importantly that their TPA treatment rates much, much higher in the mobile stroke weeks as compared to the non-weeks. Times to treatment, again, much faster on that mobile stroke unit compared to the weeks that were not available. And interestingly, if you talk about that first hour after symptom onset, the golden hour after stroke onset, again, we all know that this is a very difficult time window to treat most patients in traditional systems, but they were treating 1/5 of their patients in that treatment window. They were treating 13% of patients within that first golden hour compared to only 4% in the non-week. So treating patients in that very, very critical first hour after symptom onset. Most importantly, though, looking at the patient outcomes, you can see here with the MRS bars that those patients treated on the mobile stroke unit had improved outcomes compared to those on the mobile stroke unit, which was statistically significant. Now, the other major study, as we all know, is our colleague Jim Grotta from the Best MSU study. And they were basically, again, able to randomize between mobile stroke weeks against standard management weeks. You can see they had a good number of patients actually in this study, multi-centered trial. Mainly, most of those patients were from Houston, though. But able to get 1,617 patients in the MSU arm versus 430 patients in that standard management arm. And again, very, very interesting data here from the golden hour scenario, that first hour after symptom onset. A third of the patients on the mobile stroke unit were actually able to be treated within that first hour after symptom onset. So substantially improved time savings, many patients treated in that early window. And again, if you look at the MRS bars here, you can see that there's a important, the logistic regression, the shift. We're seeing many more patients have improved outcomes in those MSU weeks, with a number of patients receiving an MRS of 0 to 1 in that time window. Again, statistically significant with an odds ratio of 2.43. Interestingly as well, we're seeing newer agents being treated on these mobile stroke units. This was the TASTE-A trial, which is using a TNK on mobile stroke. This is from our colleagues at Melbourne. Mobile stroke versus standard care weeks. Again, you see here that even though alteplase is working quite well in these mobile stroke units, we're seeing TNK recanalizing these patients much, much better in this time window. Their study wasn't powered necessarily to see differences in outcome. Excuse me. But they were able to show a significant, less of a volume of perfusion deficit. So with this small study, again, adding evidence on mobile stroke units, a TNK may be a better agent to be utilized. So for us, I think we thought this was the right thing to do for the people of Cleveland. I think this can be expanded worldwide. Increased use of those life-saving IV GPA drugs, decreasing that time to treatment. Again, from a transport perspective, getting the right patient to the right place the first time and reducing those intra-hospital transports. And ultimately, we want to improve patients' outcomes, so we're returning patients to their home, to functions, and to their work, decreasing, demonstrating decreased healthcare cost savings, which I think Dr. Kawaja will get into a little bit later. There are still a number of ongoing questions. We're still looking at the cost effectiveness of this model. And again, I often say that it's really an excellent tool to be utilizing in a healthcare system, but obviously the healthcare system, you have to decide where you want to invest those dollars. And I think Dr. Kawaja will hopefully come into a little bit more about the cost effectiveness questions and how to make this a sustainable model. We're certainly working here in the United States to try to get specific reimbursement for mobile stroke units, seeing the value of these mobile stroke units to the care of the stroke patients. I think there's a lot of interesting questions there about what environment may be the best for these. Most mobile stroke units are currently applied to the urban environment, but we talk about how they can be potentially utilized in suburban environments, or even to provide care to patients in resource restricted settings, things like the rural areas of the United States where population density isn't as large. And sometimes we have to do a rendezvous model where we send the mobile stroke unit to be able to interface with the local teams to be able to get that CT scanner and that stroke expertise to the patient faster. And I think the other very exciting area in here is that new devices are coming out that hopefully will help with stroke detection. There's some there on the side there, some that use ultrasound technology, some that use EEG technology, electrical impedance, or even wearable devices that one can put on to a patient to kind of help to see and detect changes that might be indicative of stroke. To us, the mobile stroke unit actually is a perfect testing ground for these, because you have an environment where you're able to take the patients in the very earliest phases of stroke, be able to kind of analyze those those settings, and then when you have the best standard to identify strokes with your CT scan and stroke expertise, you can then compare it against these different devices and really understand, are they able to detect stroke in that very, very early phase, which is a very, very hard testing environment to do in any other setting. So mobile stroke, I think, is a wonderful tool, and hopefully will not just advance things in terms of this pre-hospital care, but may actually help with us understanding devices and other techniques we can use to allow earlier identification of stroke. But we're certainly very proud to be amongst the first in the world to have used these mobile stroke units. Here are the pictures of the first 4 that were established in the world. And as mentioned, I'm the president of the PRESTO, the Pre-Hospital Stroke Treatment Organization, a wonderful organization that's united mobile stroke programs from around the world. We actually, I need to add the star here, for there is actually a mobile stroke unit in Nigeria as well. So we do see them on all continents at this point, and including in the Middle East, Riyadh, and we'll hear a little bit more in a bit about the program there in Saudi Arabia, which has been a wonderful addition to our international community. So with that, I'll conclude to allow my colleagues some time to present their data and their thoughts on the subject. But really, again, mobile stroke units have allowed us to definitely have faster times to evaluation and treatment. We're seeing the again confirmed outcome benefits with the Be Proud and BEST MSU studies. Continuing studies of cost analysis are ongoing, and newer devices are going to allow us to detect patients faster with stroke, and mobile stroke again is going to be the best testing environment for that as well. So with that, I will conclude, and I think Father, we're taking questions a little later then.
Probably we're going to take the question at the end of the session, Shaz.
Perfect.
So thank you so much, Shaz, for an extremely comprehensive overview. So now it's my pleasure to introduce Dr. Fred Hosty. Fred is the Medical Director, Critical Care Transport and Emergency Medicine Physician at Cleveland Clinic. So let me go briefly through Fred's resume, which is really an impressive resume. So Fred received his medical degree from Ohio State University, College of Medicine and Public Health in 1994. Then he completed his residency in emergency medicine at Metro Health Medical Center, Case Western Reserve University in 1997. Following completion of his residency, he joined Cleveland Clinic, and he's currently practicing as an emergency physician and serve as a medical director of Cleveland Clinic's critical care transportation. Fred had published more than 40 peer-reviewed journal publication, and he's the principal investigator of some of the earliest published study identifying the quality of care issue in older emergency medicine patient. Fred also has co-directed both national and international CME courses involving issue related to the older patient, and in 2006, he named American Geriatric Society Dennis Jahan Scholar. Fred also is an associated professor of emergency medicine at Cleveland Clinic Lerner College of Medicine, Case Western University. So without further ado, Fred, welcome, and we are extremely pleased to have you with us.
Thank you so much for the kind introduction. See if I can get my screen up. Are you able to see the slides?
Yes.
Okay. All right. Well, thank you again very much, not just for the kind introduction, but also for the kind invitation to present at this great event. And so we're going to briefly touch on the importance of mobile stroke units and the timely treatment of acute stroke. Dr. Hussein already covered this pretty well. We're going to talk a little bit about different models of MSU and EMS system integration. We're going to identify some challenges associated with MSU integration and some strategies to overcome them. And so, as Dr. Hussein pointed out very well, time is brain. It's not just about the treatment in acute stroke, but it's about the time to treatment in acute stroke, because every minute that goes by, we lose roughly 1.9 million neurons, and the likelihood of long-term disability increases. Unfortunately, there are still many challenges to seeking and receiving timely medical attention. That goes anywhere from the detection of the stroke to dispatching the EMS system, delivering the patient to the ER, getting through the ER, getting all the processes done that need to be done, and then the decision to intervene, whether it's TPA, TNK, or some type of endovascular intervention. And so this is where mobile stroke units come in. The mobile stroke treatment unit, we don't wait anymore for the patient to come to the emergency room. We can bring the CT scan and the stroke expertise right to the patient. We can initiate treatment at the scene, and we can dramatically cut time to treatment and, more importantly, improve outcomes. And so there are different models of MSU EMS integration. There's the EMS embedded hybrid model where the EMS unit is kind of a hybrid between the municipal EMS agency or the fire department and then the local hospital or healthcare system. And so the crew is often a hybrid crew. You have caregivers on the stroke unit that are employees of the EMS agency that are trained by the EMS agency, and then you have employees of the hospital that are also on the stroke unit, perhaps a stroke neurologist or a critical care nurse that partner with the EMS colleagues to provide care on that unit. And they typically are based at an EMS facility. And so, the advantages of that are that, you're a constant reminder to your EMS colleagues that you're there. They know you're there. They, dispatch them with you, and you can maintain that relationship, fairly easy. The hospital-based model, which is the model that we use at Cleveland Clinic, that is a model where the mobile stroke unit, the employees, the care, the protocols, all of it is taken care of by the hospital. It's all owned by the hospital, driven by the hospital, and the hospital monitors and drives that quality of care. And that mobile stroke unit may not be based at an EMS base. It may be based at an alternative location. It may be based at one of the hospitals or another location that's centrally located, that's very friendly to responding to a variety of areas within that metropolitan area. And then, as Dr. Hussein briefly touched on, most models are urban models because of the high population density. You get more bang for your buck. The catchment area for geography is significantly smaller, and so it doesn't take as much time to go out and meet the EMS agency wherever they're at, bring the patient back to the hospital. And the drive times are not quite as challenging. Rural models of integration, and really I think these are more hybrid models where urban models are now trying to kind of branch out into rural models. So the catchment area is geographically larger. You don't have quite as many patients, and you have that challenge of distance. So, these are the people who really need, everybody needs a mobile stroke unit when they're having a stroke, but these are the people who really need it because a lot of these patients, they may be an hour or two away from the nearest facility. And so to bring the treatment to them and be able to administer it where they are, somewhere in between the hospital and the location of the event, can be huge in improving those patients' outcomes. And so for those types of programs, you really need to have rendezvous protocols. You need to work with your EMS colleagues, to have a program where, if they're responding to a patient that's an hour away from you, they'll transport that patient somewhere to a midpoint where you can meet up. The transport time is then 30 minutes instead of an hour, and you can initiate treatment much faster. And so our program started in the city of Cleveland. It's a classic urban model, high population density. First, and depending on your environment, these may or may not be challenges for you, but we had to win the community over first. And so we had to engage the community through grassroots efforts with local stroke awareness events. We had to get into the media so that the public would see, all about the mobile stroke program, the benefits of it throughout the media. And then we had to win over the local government. So we had to win over the mayor, the fire chief, the EMS leaders, the EMS commissioner, EMS medical director. And so we had plenty of meetings with that group as well, to establish that relationship and win over them and build trust. And then once that was done, we had to establish formal operating agreements with the municipalities, which detail all aspects of the protocol for interactions between the mobile stroke unit and the local fire EMS providers, because we're two separate agencies. Everybody needs to know what each person's and each unit's responsibility is. And then once that was done, we participated in the in-service training for all of the fire and EMS providers and the dispatch operators just prior to the go-live date. We had to decide when we were going to have the unit available because we didn't have the luxury of staffing the unit 24 hours a day, 7 days a week. And so we looked at when stroke calls typically happened in our community, and we found that the bulk of them happened roughly between 8 a.m. and somewhere around 10 p.m. And so for us, trying to find that 12-hour period, we started out with an 8 a.m. to 8 p.m. roughly shift. And then we had to build trust. And so again, depending on your environment, these may or not be challenges for you, but we had to show them that this is a partnership. It's not a takeover. So for us, EMS, Cleveland EMS, which is our biggest partner, initially a lot of the EMS providers, they were concerned that we were going to take over their job, that they weren't going to be needed anymore to transport these patients, that we were just going to go get the patient, take them to the hospital, and they were going to be out of work. And we had to establish destination protocols to get patients to the right facility, regardless of their health system affiliation. And so in the Cleveland metropolitan area, we have 3 large health systems that all compete with each other. And there was concern that, this mobile stroke program that we had was going to be more about stealing patients and bringing them into Cleveland Clinic than it was about, trying to make a difference for patients, which is really what the goal of the program is. And so we had to develop those protocols and be very transparent with those EMS agencies and the other healthcare facilities and the government, to show them that, we were going to be fair, in how we were managing this. And then we had to participate in the education of EMS providers. And so this is one example of our triage guideline that we developed. In a nutshell, you know, it kind of goes through a workflow of who needs to go to a level 1 stroke center for the mobile stroke unit, who could go to a 1 or a 2, who could go to a 3, and then who could go to the nearest facility with neurology coverage, because it sounds like it really was probably a non-stroke event. And then the crews all know geographically where each of these hospitals are, where the closest level 1 is based on where they're at, where the closest level 2, the closest level 3, and the closest facility in general. And those are the guidelines that they follow. And so flexibility was also important. We're currently covering 13 municipalities now in Northeast Ohio. You know, if you look at the metropolitan area of Cleveland, Cleveland is here in the center area, one city, but the Cleveland metro area is made up of multiple suburbs, which are all each individual municipalities, each individual cities that have their own EMS agencies that we had to work with and develop protocols for as we expanded. And so we had to adapt dispatch and response protocols to meet the needs of each of these EMS organizations. To give you an example of the variety, so Cleveland EMS, they use a CAD system like a computer tablet that they're dispatched from. We carry that same tablet that the Cleveland EMS providers do. We get the same information that they get when they're dispatched, and that's the system that we use to operate. And we have other municipalities, though, that prefer to communicate by radio, and so we had to invest in radios, program frequencies so we could communicate with them. And there are still a few small organizations that prefer to communicate with us by cell phone. And so they will actually call us on the cell phone to dispatch us as well. So we had to meet these agencies where they were at. We didn't insist on them conforming to our method of operations. And then we developed the tailored legal agreements and contracts. And we did develop some rendezvous opportunities for some of these agencies that were further in the periphery so that we could meet them halfway and initiate treatment much faster than if we were going all the way to meet them on the scene. Setting clear dispatch and transport protocols is also very important. You know what you want to catch. We're looking for patients who we can intervene on, those that are eligible for time-sensitive interventions such as TPA, TNK, or endovascular therapy. And so what we were looking for is anyone who called the emergency system who had symptoms that could be possibly related to a stroke, and their last known well was less than 24 hours, and that would trigger the mobile stroke unit dispatch. And then the EMS providers, when they would get on scene, if they had a positive Cincinnati or they had another concern for stroke with a last known well less than 24 hours, that would trigger us to interface with the patient and then transport that patient and take care of them. We also build in a wait time for EMS because under some circumstances, depending on traffic or what else may have been going on at the time, we may have a delayed response. And so we did not want them sitting at the scene if they were ready to transport the patient for an inordinate amount of time where it was going to be detrimental to the patient. And so we developed a protocol where they would wait 10 minutes after they were ready to transport, and if we still hadn't been able to arrive at that point, they would take the patient to the closest, most appropriate facility. So one of the big challenges is getting that population that you really are targeting. And as you can see, our completion rate, and this is our most recent data for the rolling 12-month period between 2024 and 2025, our completion rate is roughly 17% averaged over those months. And by completion rate, I mean that for every call that we're dispatched on, how many calls do we actually go and take that patient and then take them to, we're the ones who own that patient and transport that patient. And this is where it does become very challenging, because when somebody calls, in our health system 911, and they're talking to an EMS dispatcher, they're not spending a ton of time sorting out the details. So somebody could call and say, hey, I'm dizzy. And the dispatcher will say, okay, well, that could be a possible stroke. How long have you been dizzy for? And they say, oh, I've been dizzy for about 2 hours. And they say, okay, that dispatches the mobile stroke unit. But what they may find when the mobile stroke unit gets to the scene is the time was greater than 24 hours. It wasn't really 3 hours, which does often happen. Or the dizziness may be related to something completely different, because when the mobile stroke unit gets there, they find that the patient's blood pressure is 80/40, and the dizziness is really from hypotension. And so, again, these are sort of very difficult to hone in on. The one thing we don't want to do is we don't want to miss patients that we can make a difference on, because if we narrow the criteria too much, there may be a patient who does really have a stroke who can benefit from thrombolytic therapy, and we don't have the opportunity to do that with that patient. We're able to handle that right now because of our volume, but it is something that we've been keenly watching. And then the final diagnosis of stroke for all of the patients that we do transport in our mobile stroke unit, about 57% of those patients will have a final diagnosis of stroke. So again, You know, that's I think one of the bigger challenges with mobile stroke units is trying to really narrow that dispatch protocol down to where you're getting that population that you're really looking for. It's very important to keep EMS engaged and to maintain that relationship, and part of that involves providing feedback. And so every EMS agency that we have a relationship with gets a PowerPoint presentation every quarter with metrics, both their individual metrics as well as how the program is doing in general and how they stack up against the other EMS agencies. And so this is an example, for example, one of the smaller EMS agencies, Garfield Heights. As you can see, the top Cleveland EMS is by far our biggest partner. They have the largest catchment area, but you can see how many dispatches you made for the mobile stroke unit and how many transports that resulted in compared to your colleagues. They also get, for their department, each of their own individual metrics. So alarm to scene, scene to door, door to needle, alarm to needle, the total dispatches, total transports, endovascular therapy, hemorrhagic stroke. They get all of these metrics so they can see exactly the difference that they're making and where they might need to, we might need to work on some opportunities for improvement. They also get how the program is doing in general. And so this is our latest slide for our program, our 2025 door-to-drug times for the mobile stroke unit. And so our average for 2025 is 16 minutes. You know, and this is really a testament to the mobile stroke unit crews and how efficient they've become. I do have to give a shout out to them. I think our record for our door-to-drug time is 8 minutes, you know, which is truly impressive considering everything that needs to be accomplished during that time. But what really testifies to the partnership that we've built with our EMS colleagues is our alarm to needle time in minutes, because we couldn't do this without them. You know, we're dependent on them to really notify us, call us, and have a seamless transition when we get to the scene so that we can take ownership of that patient and get done what we need to get done. And so you can see our alarm to needle time for the rolling 12 months up through August of this year, we're consistently below 45 minutes. We're usually below 40 minutes from the 911 call until that patient has received a dose of thrombolytic. And so I wanted to close by playing just a short video, and this is an actual patient that was cared for on a mobile stroke unit and kind of talks about the process. If you could just bear with me for a couple minutes.
Stroke is a neurologic emergency. For every minute that the brain goes without blood flow, 1.9 million neurons are dying. We have a saying in neurology that time is brain.
My mom is, she can't speak. She tried to say something to me, and then she got really scared, and then she started slurring all of her words. Okay, can you ask her if she has any history of stroke? That's what she thinks it is. She thinks it's a stroke? Yeah.
On our way to the scene, we're thinking, okay, stroke symptoms. Time is important on a stroke call because we do not want their condition to worsen. How do you feel today? Can't talk? A little confused?
The paramedics arrived and they determined that it was a stroke, and I still confused and not sure what was happening, but they said, we're going to get another van over here just for strokes.
When we get on scene and we have the mobile stroke unit already on its way, we know that the highest care is being brought right to the scene.
The mobile stroke unit brings not just the ambulance and the medication and the personnel to deliver it. They bring the lab, they can do blood tests on the spot. They bring the CAT scan to the patient. They bring the neurologist to the patient.
When I was paged, I was sitting at the computer workstation where we do our telemedicine evaluations. I electronically dropped specific orders in to the chart for that. Okay. I have a CT scan of her head for her to have specific blood work to evaluate her. And I beamed into the ambulance, and then I saw Loretta and I started talking. And immediately it was obvious that she was having trouble talking. Can you tell me what your name is? I'm performing a rapid neurologic assessment we call the NIH stroke scale. She did not have significant weakness at the time. Her main symptoms was her speech disturbance. In evaluating her, I determined that she was having a stroke and that her predominant symptoms qualified her for the clot busting medication TPA.
Okay, TPA, that's been starting.
We were able to administer that medication in a very short period of time. The more rapidly we administer the medication, the more rapidly we restore blood flow, the greater the likelihood is that it'll have reduced disability and better function after their stroke.
I recall some kind of medicine in the IV, and all of this was happening while I was still in the parking lot, and it was like, wow.
After receiving the medication, she was then immediately transported over to the Marymount emergency room.
I arrived at the emergency room, and they told me the stroke was over. And I was blown away.
On a daily basis, she improved. So first she was able to get more words out, and then she was able to get them out with greater ease. And this continued every single day until the day of her discharge.
To say that I had this big stroke, and it was, less than 2 weeks ago, and all I have is a little bit of stumbling of my words, and everything else is gone. That is incredible to me.
It is a game changer. It is a major event in the history of neurology and medicine.
This type of program would not be possible without the generous contributions of private citizens, such as the Maltz family. And in their contribution to create the mobile stroke treatment unit, they're able to realize a dream of creating the most effective system of stroke care that we can offer.
Oh, I can't even say how grateful I am. Those folks, they were all doing what they needed to do, and they did it quickly. And to say that I was lucky doesn't even cover it. I feel like the luckiest person on the planet. Absolutely.
And so, concluding, there are a variety of different models for MSU-EMS integration, and strategies will really, vary based on the local landscape. And I'd also like to thank Shazam for sharing some of the slides that he has for this presentation. And thank you very much.
But thank you so much for such an elegant presentation. Personally, I think, Fred, I need to spend 30 minutes with you, learning from you some of a few things. This is, at least for me, but we will keep the audience question to the end. So now it is my great pleasure to introduce Dr. Zeeshan Khawaja. Zeeshan is a great friend and colleague. He's the Medical Director of Documentation of Excellence and the Medical Director of Telestroke at the Cleveland Clinic, Ohio. Zeeshan is the vascular neurologist at the Cleveland Clinic, where he served as the medical director of the Global Documentation Excellence Program, as well as the medical director of Enterprise Telestroke Program. He received his medical degree from Sapa University School of Medicine and trained in neurology at the University of Florida before undertaking a fellowship in vascular neurology at the Cleveland Clinic. Dr. Khawaja went on to earn an executive MBA from Weatherhead School of Management, and he is an associated professor of neurology. Since he joined the Cleveland Clinic Stroke Program in 2013, he held multiple leadership roles and authored many book chapters, and did many national presentations on topic includes stroke, mobile stroke units, cerebrovascular diseases, and clinical documentation integrity. So without further ado, I would like to welcome Zeeshan, and I'm sure that we're going to enjoy his presentation.
All right. Well, good evening, everyone. Are you able to see my slides?
It is clear.
Yes?
Very clear.
Perfect. All right. Well, very tough act to follow, such an emotional video shared by Dr. Husty that really shows the impact of mobile stroke units. This is not an uncommon story, and I think it's wonderful to see what the impact of mobile stroke units is to patients, how they're able to regain their independence. And Dr. Hussein gave a fantastic presentation on the evidence behind it, on how time saved can help reduce disability and really what the clinical value is. And so I'm going to switch gears a little bit and talk about if mobile stroke units are a good investment for you. And if you don't have a mobile stroke unit and you want one, what do we need to consider, before knocking on the door of our board members or our hospital leadership? And so Shazam kind of shared this picture, and I had a little bit of difficulty truly figuring out how many mobile stroke unit programs there are because they are growing so much. But one of the things that we'll see is that this is a global program. In the US, there's more than 20 MSUs alone. And if you look at Thailand, they're planning 21 to basically cover their entire country. And this expansion, again, reflects growing evidence that supports the value of pre-hospital care in helping deliver rapid and effective stroke care that reduces disability. But the one thing that you'll see is that adoption is limited mostly by some of the economic and operational considerations. Mobile stroke units are not cheap, they're expensive. And so how do we know if it's going to benefit our community? And then below, you'll see kind of how far we've come. Over the years with the first MSU concept in early 2000s, and as Dr. Hussain mentioned, in 2010, 2011, seeing some of our first MSUs, and then in 2014, our first MSU in the US. Following that, lots of publications, and then expansion, rapid expansion since. And so what is the economic question? Number one is, what is the impact to the bottom line? What are some of the incremental costs of implementing a mobile stroke unit versus our, versus standard EMS pathways? And secondly, is it cost effective? How are we measuring the value of a mobile stroke unit? We all know from what we've heard from Dr. Hussain's presentation and the video before that it works, that we can get to patients, we can treat them on their driveways, at their homes, and see significant clinical benefits. But how does that translate to an incremental cost effectiveness ratio and qualities? And then lastly, from an operational threshold, what communities or geographic locations will benefit most from having a mobile stroke unit? And so I'm going to review a few mobile stroke unit economic studies that evaluate these critical dimensions. And I think understanding these will be critical to see if a mobile stroke unit is a good investment for your area. And so I'm not going to spend too much time going through here because, again, Dr. Hussain gave a fantastic presentation. But one of the things that you'll see is that when we're able to achieve functional independence, the total cost of care is significantly lower than when patients are disabled. And most of that is in the post-acute space, right? So the direct cost of nursing care, of rehabilitation, the indirect cost of not being able to work and dependent on government resources takes a huge toll on our society. And you can see the 5-year costs are hundreds of thousands of dollars compared to somebody who is functionally independent. And we know that interventions such as IV thrombolysis and endovascular therapy are huge contributors to sparing disability. If we move and start talking about some of the startup costs with mobile stroke units, the first thing to understand is that it's highly variable. It is entirely dependent on what vendors you go with. Are you going to go with Fraser or Excellence? What type of CT scanner you're going to be using? What kind of lab? What kind of telemedicine infrastructure? There are a lot of vendors out there. And depending on what part of the world you're in and who you're choosing, your cost will highly vary. Secondly, most of the cost is upfront. So it's a very, very large upfront investment, most of which comes from the construction cost of the mobile stroke unit itself. If you look at the annual operating costs, that can vary significantly depending on your staffing. And so Dr. Husty, again, gave a fantastic talk on how we operate our mobile stroke unit and some other ways of operating it. But that can vary depending on what your support staff looks like, what your administrative staff looks like, who's in the unit, and how you're utilizing a physician, either sitting in the mobile stroke unit versus being virtual. And then, of course, other costs, equipment servicing, and then your inventory. From a staffing model, once again, that provides some highly variable costs. Here we use, we have CT techs, paramedics, registered nurses, and a vascular neurologist. And then, as Dr. Hussein mentioned, earlier, it's limited reimbursement. There are very few programs that are receiving complete reimbursement, and so that can significantly impact some of the operational costs within MSU. So I'm going to get into some cost consequence analysis. So here at Cleveland Clinic, we did a study looking at what the incremental cost is in a year of providing care with a mobile stroke unit versus standard transport, which is our EMS. And you can see here the total cost using standard transport was about $785,000. Again, using traditional EMS to hospital with in-hospital treatment initiation, whereas with MSU, it was a little over $850,000. And the incremental cost was a little bit more than $70,000 with a mobile stroke unit. But what we found is that there was a significant cost offset, and that comes from avoiding interfacility transfers, including very expensive air ambulance transport. And so again, you're going to hear it, getting patients to the right place the first time. That is a significant advantage of using a mobile stroke unit. By having the ability to evaluate patients in the unit, we can get a better idea if there's a large vessel occlusion, bypass a primary stroke center and getting them to a thrombectomy stroke center or a comprehensive stroke center. If we see a hemorrhage, going straight to a comprehensive stroke center, whereas with traditional care, that patient would get a scan, would have to be, again, routed to another hospital, costing precious minutes and resources. And so when we look at the incremental cost, one of the takeaways from this study is that it must be weighed against savings from the transfers and also improved patient outcomes that come from treating patients faster. If we look at a Norwegian health economic model, here what they did is they created a model using the TREAT and ASPP study data, and they basically developed a decision tree and a model to simulate lifetime health and cost outcomes in a mobile stroke unit versus standard transport for about 25 cycles or 25 years. And they combined some of the results with CIST and pooled analysis from a few other studies to determine outcomes. And what they found is that there was a 13-fold increase in golden hour IV thrombolysis, about 15.2% in MSU versus 1.2% with standard transport, and significantly more IV thrombolysis in a mobile stroke unit. And although there was a slight increase in the incremental cost of about $4,000, there was a significant health gain of about 0.065 QALYs. Largely driven again by higher IV thrombolysis and also a significant reduction in the time to treatment. And so if we look to see if it's cost effective, basically in scenarios where they're treating about 260 patients or more on the unit, the cost effectiveness threshold is met if it at $43,000 per QALY, which is below the national willingness to pay threshold. And so again, this is, these metrics basically look at what the willingness to pay threshold is what is society willing to pay to reduce disability or to improve the quality of life by 1 QALY. And this in this study met the mark. And a lot of the lifetime cost was offset by some of the lower rehabilitation and care costs. Because again, we're treating patients earlier, we're reducing disability. And if we reduce disability, there are less direct and indirect costs associated with stroke. Moving on to the Melbourne MSU study that was cited a little bit earlier. Again, I'm just focusing on some of the economic portions of these studies, but they basically found that there was significantly more endovascular therapy in the MSU group at 40% versus 23%. The outcomes were much, much better, more functional independence, less mortality, but again, increased cost. And so if we look at if there's cost effectiveness here, they basically found that early reperfusion was a primary driver of cost effectiveness, and again, driven by more stroke treatment, faster stroke treatment. looking at a systematic economic review. There was a comprehensive review that looked at MSTU time metrics, clinical outcomes, adverse events, and cost effectiveness. But again, I'm going to focus on some of the economic portions of the study. And there were economic analyses available in 4 of those studies. And basically what it found was, again, a mean reduction to treatment of about 32 minutes and a significantly higher functional independence. And what that led to was a benefit cost ratio of about 2 to almost 7. And again, what that reflects is a significant return on investment to patients and to society. And this was largely dependent on staffing and radius, right? So the tighter the radius, the more patients that they were able to capture, the more patients are able to treat and see, then the higher the benefit cost ratio. And in Phantom S, they basically found an expected health benefit of almost 30 QALYs per year. And it was cost effective in 90% of the simulations, which is quite incredible, with an incremental cost effectiveness ratio of about 31,911. So again, demonstrating cost effectiveness across several economic studies. Here, if we look at a prospective study, Dr. Sain talked about BEST MSU. They also evaluated the cost effectiveness and basically found that in the first year, that cost effectiveness was basically borderline, but demonstrated significant cost effectiveness in patients that were treated who did not have a baseline disability. And so this was largely, again, driven by the high costs in the first year with MSU development. But it again kind of highlights that cost effectiveness will depend on where you are and how long you're following patients for. So there's a few key operational considerations and that I'll talk about. Some of it that's already been mentioned. And so it's really important to consider your staffing and your coverage models. Your personnel and your operational hours has a significant impact on the cost effectiveness of your program, right? And so if we look at the population density and coverage in general, a lot of programs will be covering in less than 20 miles. And so imagine if you are all the way on the east side of your coverage map and there's a call on the west side. Sometimes you can't get there in time, right? It might, depending on how much traffic there is, depending on your specific geography, even with the rendezvous point, it might be difficult to care for patients. So it's important to carefully consider the population density and the coverage area. Transfer avoidance is also really, really important to consider. That if you're in an area that has a very large concentration of primary stroke centers, or other hospitals that don't necessarily have neurology coverage 24/7, and there's a lot of transfer that tends to occur. That is something that to keep in consideration when we're talking about if an MSU can be cost effective for you, and then also coverage hours, right? And so it's important to make sure that MSU is available when strokes are happening. Of course, if you were to run an MSU program that was 24/7, you would help patients, but there could be a large chunk of time when that mobile stroke unit is not used, and that would increase your cost base. So if we talk about the reality of mobile stroke unit program finances, there was a study in 2023, a survey, and they surveyed 33 programs, and it had some interesting results. The median startup cost was about $1 million, and the median staffing was about four staff in the mobile stroke unit. If you look at the finances of the program itself, the vast majority of programs were actually losing, not vast majority, but a little bit more than half were losing money from their mobile stroke programs. A very small percentage, again, were neutral, and then you had a small proportion that was positive. So most programs, unfortunately, were losing money. And 94% of the programs reported financial challenges, but continued operations just because of the clinical value and their ability to pull funding from other areas. And if you look here at how programs are funding their mobile stroke units, you can see these numbers add up well more than 100%. And so it's clear that, programs are using various or leveraging multiple sources of funding. The most common being philanthropic support. So getting donations, like Cleveland Clinic, we were able to get some support. You can see that government funding, hospital investment, and reimbursement is pretty even, and then non-governmental foundations. But the most common scenario basically is getting support from different areas. Only 12% of programs reported full reimbursement, while 47% reported some reimbursement. So again, that diversity of funding reflects how challenging it can be to sustainably fund these programs. So if we move on and start looking at some of the evidence gaps and limitations, number one, it is hard to generalize any results. Understanding that Germany is different, the cities in Germany are very different from Cleveland, which is different from Texas and New York. Very, very different, and of course Melbourne. So every area will have its own challenges, and it's very, very important that to look at the data in your area individually before generalizing these results. And we know that cost of utilization tracking beyond the initial study, it can be limited, affecting our lifetime cost effectiveness estimates. So if we're not following these patients long term, then sometimes we can underestimate how much value these are really bringing. And then also the operational heterogeneity. There are a lot of programs that do things differently, whether they're running 7 on, 7 off, if they're running 12 hours a day, 24 hours a day. And so again, every community has its needs, and those things need to be taken into consideration. So if we're thinking about the strategic investment framework, we know the clinical value now, right? We know that MSUs lead to earlier reperfusion, improved outcomes, it reduces disability, enhances our quality of life, and if it's done correctly, in the right environment, it can bring financial value by reducing secondary transfers, by lowering long-term costs, and also can be favorable from a cost effectiveness perspective. And so really, it's important. It requires some careful planning around our volume thresholds, operational efficiency, and diversified funding. And then lastly, should we invest in an MSU? We know that there's some evidence that supports cost effectiveness, but again, really important to look at your city, to look at your community, to see if an MSU would be cost effective. We know it's highly dependent on volume. The more patients we're able to treat, then the higher that cost effectiveness ratio becomes. And then, of course, local adaptation. So it's important, again, to apply this evidence to your specific context. And then the last thing I'll say is that mobile stroke units serve the community. Mobile stroke units are not good to divert patients to your hospital. They're definitely not money makers. It's really a community service, and very pleased to see mobile stroke units growing throughout the world. And with that, thank you.
Thank you, Dr. Khawaja, for this outstanding and educational presentation. I personally learned a lot, especially on this part of cost effectiveness and economics that we, as a clinician, sometimes misunderstood it. Thank you very much again. I would like to welcome Dr. Ahmed Al-Khairi, who will present the last lectures today of the session, titled The Saudi Experience During Hajj, Launching Mobile Stroke Unit Under Unusual Circumstances. Dr. Ahmed Al-Khairi is a BGY1 neurology resident at King Faisal Specialist Hospital and Research Centers in Riyadh, Saudi Arabia. He completed his medical degree at King Saud bin Abdulaziz University for Health Sciences in Jeddah, Saudi Arabia, and graduating as the first honor degree last year. Joined the King Faisal Specialist Hospital. His academic interest focus on clinical neuroscience, particularly in research, methodology, and evidence-based scientists. Dr. Ahmed, please start your presentation. The floor is yours. Thank you.
Yes, thank you, Dr. Saeed. Thank you, everyone. First of all, Assalamu alaikum. This is Ahmed Al-Khairi. I'm delighted today to present and talk about the MSU experience during Hajj 2025. I'm very delighted to present this on behalf of all the teams participating in the 2025 Hajj. Starting with the MSU, as we heard from Dr. Shazam and other doctors, that MSU works in clinical setting, but it has never been implemented in mass gathering setting. So that was our goal. So today I will talk about the Hajj and Hajj routes. We'll talk about the stroke burden during Hajj and the MSU as a strategic public health solution in a mass gathering. Lastly, we'll end with the Saudi 2025 MSU experience during Hajj. Hajj is very important. It represents a very important aspect to all Muslims. It's the fifth pillar of the Islam, and each Muslim needs to, or should do it at least once their lifetime if they are capable. It includes multiple rituals across 5 holy sites in Mecca city in Saudi Arabia, and visitors from all across the world, Muslims from all across the world come to visit Mecca. So mostly this is different from the in the Gregorian calendar. However, in the Hijri calendar, it's starts at the 8th and end at the 13th, and pilgrims usually arrive weeks and months prior to Hajj rituals and stay even further after that. So Hajj process start when pilgrims arrive to Mecca. They arrive weeks and to the start of the 7th day of the 12th month of the Hijri calendar, Dhul Hijjah. They start arriving at Mecca. They head to the Masjid al-Haram to start their ritual. Then at the 8th day, one day after, they head to Mina. Afterward, they head to Arafat at the plain of Arafat to spend the day, and at night of the same day they move to Muzdalifah. They spend the night at Muzdalifah and then back to Mina, and from Mina pilgrims go back and forth to do the stunning and also go to Masjid al-Haram. So every year around 1.5 million to 2 million pilgrims arrive to Saudi Arabia and to Mecca. And to understand this concept more, 1.5 to 2 million mostly constricted in this area and concentrated in this area, the area of the ritual sites. And this represents around 117 kilometers squares. So, but it's not that simple, as the 1.5 or 2 million pilgrims at each single time point, they will be placed at a single ritual site. So if you take, for example, Masjid al-Haram with 350 meters square, so it will be the approximate pilgrims per meter will be 4.5 pilgrims per meter square. And this is the this also extends to Arafat, Muzdalifah, and Mina with less density. So to understand the magnitude of the problem, Dr. Mohammed Al-Mukhlafi in 2015 did a study using a prospective registry, Hajj stroke registry across 6 hospitals in Mecca. And what they found that the incidence of stroke during the 2015 Hajj season was 8.9 per 100,000. And the peak incidence was noted at the day after Arafat. However, only 5 patients, and which represent 2.7 of the population, received thrombolysis. So digging deep more into the data, they enrolled 186 patients, mostly older than 50, 60 years old. And when we look at their time data, the onset to arrival times were at a median of 7.4 hours, and the time from arrival to imaging was around 1.5 hours. So, and most reason for not giving or withholding TBA were due to delay either at the pre-hospital or due to delay at the hospital, inside the hospital. So to understand the stroke flow during Hajj in previous years, so mostly this start with the EMS alert or a direct presentation with the patients to the infield ER hospital. And if it's the EMS, due to the high pedestrian density, mostly will use golf carts for mobility there. So these either present at infield hospital with a CT capability, or to infield hospital without CT capability, which would require a transfer back to infield hospital with the stroke capability. And all of these will be either direct or subjected to infield medical contact, which is rarely done during Hajj, and mostly will be done through online telestroke communication platforms. But this is all at risk, especially to accessibility and mobility. So this is what Hajj looks like. So during Hajj, this is the Ajad Emergency Hospital, which is the main hospital in Masjid al-Haram, and this is the pedestrian density around it. So it will be difficult for EMS services, for patients to arrive even at the corridors of the hospital at the first place. And this is at Mustashfa, at Mina. So and we can see that there is doctors even doing the triage at the outside. So stroke has like special scenario during Hajj. Patients are subjected to difficulty in accessibility and mobility that include traffic, roads filled with buses, crowd controls, multiple checkpoints, hospital volumes, and ER triaging, and also the difficulty to transfer to AVT centers. And during Hajj, the demographics, most of the patients, or a significant proportion of the patients, are older than 50 years old, multiple comorbidities, and there is high risk of medication disruptions due to transfer and multiple transfer between sites. And also there are patients subjected to that mass gathering factors that predispose them to stroke, that include significant dehydration, sleep deprivation, exertion, exposure to sun, and also language barriers. So the important solution, or one of the solutions, back again to what Dr. Shazam Hussain said by Dr. Michael Hill, we cannot expect the patient disease biology to match our system because the time window to treatment for stroke with most is so short. So we must match our system to the biology. So one proposal is through the application of mobile stroke unit. But let's get one step back. As Dr. Shazam Hussain said, the evidence of mobile stroke unit is already there. I'm not gonna bother you with the stats that was Dr. Shazam wrote. However, mobile stroke unit have never been applied in a mass gathering setting, and most application and all application in rural and pedestrian and routine stroke services. So the application of mobile stroke unit is actually aligned with the national vision and mission. So it's to apply an advanced and to innovative healthcare solutions as a public health solution for the mobile stroke unit, also to reduce the burden on the healthcare systems and to provide highly specialized care in restricted time and space areas. So going back or going to the mass gathering medicine in general is new. So first description was in 2014, and most of these were, or most of the discipline were focused on the communicable diseases, thermal disorder, but there is little application to stroke, and it could be even to none. So the MSU proposal during Hajj is to provide a strategic opportunity for advanced and specialized care, and this would only happen if there is with high level of coordination, either with the medical and regulatory services, and also with the awareness, appropriate awareness. So it's either awareness to stroke either identification and treatment, and also awareness of the role and the capability of the mobile stroke unit, and this extends to the MS, the ER physicians, the pilgrims, and to the regulatory services. And again, the MSU proposal is need to be addressed to special needs. So the positioning will be different than the usual application of mobile stroke unit, the catchment zone, and also the pathway and dispatch. So goals and aims was to provide timely triage, timely stabilization of patient, timely treatment, and to provide optimal data collection for future opportunity and improvement. So this is the King Fahd Specialist Hospital mobile stroke unit. Will not go into the details of what's inside and what's not. So basically, it's a mobile stroke unit with the CT capability and point of care, and also with the stroke box medicines. So the staffing during Hajj was composed of a critical care stroke trained nurse, but also with the licensed and stroke trained paramedic, with the licensed CT tech, and with the vascular neurology, most of the time through physical and sometimes through tele-stroke communications. So to understand the MCU position, we need to get back along the routes of the Hajj. So from the arrival, we plan to position the MSU in the area of the highest pedestrian zone. So the first positioning was to position in Masjid al-Haram, as most of the pilgrims first would arrive at Masjid al-Haram. So from the second day of Dhul Hijjah to 8th day of Dhul Hijjah, we will be placed, or we aim to place at Masjid al-Haram, or Haram Hospital, Haram Yar Hospital, and then we will be moving with the pilgrims. So when they move to Arafat, we will be moving with them at the 9th day of Dhul Hijjah. So we'll be placed at the area, even in Arafat, at the highest area, with the highest pedestrian area, at Jabal al-Rahma Hospital. And from the 10th to 13th, we will be back to Masjid al-Haram. So throughout this time zone, or throughout this time period, there will be 24-hour coverage throughout Hajj days. So the MCU workflow was planned to be the EMS, the MCU alert will be received either through emergency department at a nearby hospital, or EMS and Red Crescent service, or through an MCU paramedics from in-field triaging. And then the alert of suspected stroke case will be received. There will be a process of identification, triaging, and initial stabilization within the MSU, and there will be simultaneous imaging and point of care laboratory imaging, as it will be the application or the workflow as any mobile stroke unit. But what we face is during Hajj, there is a significant language barrier, and this mainly stems from the number of external pilgrims nationality, and this year it was around 171 nationalities. So to address this, prior to our implementation, we arranged for a large language model application to translate and provide pre-recorded translation of NIHS and history element, translate to 12 different languages. And we identified those different languages based on the brochure that Saudi Arabia government provided for as e-guides for pilgrims. So we provided 12 other different languages other than Arabic and English. And this would work either through identification of patient voice or relative voice through AI application, and then we use the pre-record translated templates. So after identification and after triaging the patient inside the MSU, doing the non-contrast CT and the point of care, there will be the clinical decision making to either proceed with IVT, EVT, or reversal of anticoagulation and management of blood pressure. And what we did is also we did a programmed or a structured patient dispatch. So this would work how if patient with disabling stroke and it's not for IVT or EVT, and patient with minor stroke and TIA, we would refer them to the primary or secondary hospital with the stroke services. And if it's a large vessel occlusion or intracerebral hemorrhage, there will be a direct transfer to a comprehensive stroke center. And in the case of disabling stroke that's treated with the IVT, there will be either referral back to a nearby hospital for observation, or if the case is eligible for EVT, to be referred to a comprehensive stroke center. And for stroke mimics is to referral to a nearby hospital. So here it comes the second day of the Qaeda, which is at the 28th of May. We started the first day. The first call we received at 9 o'clock. So 9:50, the patient, the first patient was brought as a walking by the family. The patient was brought by NHS 17. The CT contrast was done, and time to CT was only 7 minutes. And this is the images from the telestroke communication. So for this patient data, as an illustrative case, this patient presented first with the last known well after Maghrib prayers at 7 p.m. Arrived at the mobile stroke unit at 9:50, then with an IHS of 17, 7 minutes after the CT was done, aspect of 8 was identified, and a tenecteplase 17.5 milligram was administered at 10:06. CT was done 3 minutes after, CT angio was done 3 minutes after, which showed left M2 occlusion, and patient was planned to go for EVT. However, the patient was unstable, so the dispatch position was transferred to a nearby hospital for stabilization of the patient. We repeat the CT at 12 a.m., which showed no hemorrhage, and the patient was referred to King Abdulaziz Hospital at Mecca. So just for this, the first case, the door to CT time was 7 minutes, and the door to tenecteplase was 16 minutes only. So this is the patient, and this is after 72 hours when you at evaluation, given that the patient was received tenecteplase but did not receive thrombectomy. So
venu avec le pèlerinage pour la première fois. Bon, en tout ce que je peux comprendre, comme je ne suis pas médecin, je ne sais pas s'il y a d'autres. Maintenant là, le moment là.
So basically, this is the observation 72 hours after administering tenecteplase to the first patient. As translation, the patient is by his own words cites that I was in a difficult state. I feel that I have almost recovered. I think I can run now, and all I want is to complete my pilgrimage. So this ends the first round, which was in Masjid al-Haram. We also received multiple other calls. Now for the second round, we transformed, or when we positioned at Arafah Hospital. And as the Prophet Muhammad said, Hajj is Arafah. This is it's carry like multiple meanings, especially for us Muslims and for pilgrims. However, it's also important to understand that this is the most or the day that most pilgrims get exhausted. The highest volumes of ER visits will be at that day. So at Arafah, when we positioned at Arafah, we received 8 cases through 19-hour operational times. And in the peak hours from 2:30 to 4:30, we received 5 back-to-back cases. Those cases were treated as ICH. First case as ICH with intraventricular hemorrhage. The second as a left M2 occlusion. Again, the door to CT was 9 minutes, and the door to connected place was only 14 minutes. We received also a call for a seizure and for ischemic stroke in the patient with infective endocarditis, and a call for a syncope. And this is the overall Hajj experience for the mobile stroke unit, and this is the data. So we received 28 calls, median age of 66.5, and 22, which equals 78% were males. There was 18 different nationalities, and the IVT rate was around 25% of stroke cases. And only 3, which equal to 10% cases, were transferred to a tertiary center, and onset to door times was 88 minutes. Time from call to MSU door was only 6 minutes, and door to needle times was around 15 minutes. Door in, door out for all patients evaluated was 22 minutes. So not only that, for the dispatch diagnosis, 8 patients received diagnosis of ischemic stroke, 1 patient of hemorrhagic stroke, and multiple other stroke mimics also were identified with 21% of cases as a syncopal attack or dizziness, confusion 17%, traumatic brain injuries in 14%, seizures in 7%, and migraine and functional neurological disorder in 3%. So to compare this to previous literature, when we go one step back to Dr. Muhammad al-Mughlafi studies done in 2015, when we look at the onset to arrival times, it was around 7.4%, and times to imaging was from arrival to imaging was 1.5 hours. So when we look at our own data, the thrombolysis rate increased from 2.7 to 25%, with 10% cases transferred to tertiary hospital, and onset to door times was only 88 minutes compared to 7.4 hours in previous literature. Also, the median time from arrival to from MCU door to treatment, door to needle time was 15 minutes compared to 1.5 hours at the regular pre-MCU settings. So this is I asked Dr. Fahad to steal Dr. Shazam's slides. So this is from Dr. Shazam's slides today. So to compare this to established system and to MCU system across the world, when we look at our own data, we see that we even triaged patient faster, because mainly probably that's due to we were in the lead, and in case of any stroke, we'll be the first responded there. So that as a comparison. And when we compare this to, compare our time to established literature about mobile stroke unit in the systematic review by Dr. Turk, we see that shorter time or shorter onset intravenous thrombolysis time in the MSU versus usual care was reduced by 31 minutes. And if we compare our study to our MSU implementation to previous study, it was reduced from 1.5 hours to 15 minutes only. So also important aspect is the dispatch diagnosis. So we not only treat ischemic stroke patients, we also evaluated and triaged a variety of suspected stroke cases. And this was mainly the aim of the mobile stroke unit. So we reduce, or this may reduce the burden on healthcare system, and we also provide the advanced, accurate, and timely triaging. And actually, in fact, it provided more than a stroke unit and provide more like a mobile urgent neurological care unit during mass gathering setting. And if we got also back to the dispatch diagnosis and to time from onset to door times, we can see that if we in usual MSU setting, this is what Ajad Hospital, emergency hospital will look like. And this is the times from Ajad Hospital to the nearest to the tertiary hospital, and this is taking just now the time. So 22 minutes in 8 o'clock in a regular day. It's different than Hajj. It will be around 3 2 hours transfer during Hajj. So this shows the magnitude and the importance of and the timely importance of applying mobile stroke unit during this past experience. And also take one step back, we also only transfer 3 cases to tertiary care hospital, and this may be a great driver, as Dr. Sichuan just stated, for cost effectiveness in such a setting. So as a concluding remark, the MSU during Hajj did a fair job. It provided excellent advanced specialized care. However, there is some areas for improvement, and most importantly is to streamline the whole healthcare system, especially for stroke and stroke pathways. This need to be implemented across the regulatory and also the medical expertise, including EMS and ER physicians. Also, we think, or in our audits, we ask ourselves a question about our positioning. So we positioned in Masjid al-Haram, then in Arafat, then we got back to Masjid al-Haram. However, we think if we placed or if we were based in Mina, we will be catching more stroke cases, as 3 days of the 6 days was Belgians were going back and forth to Mina. Also, important remark is to point toward the awareness, increase awareness across the EMS, the ER, and the Belgians and the regulatory authorities to the importance and to the timely applications of mobile stroke unit and the potential advantages associated with this. And at the end, I would like to thank all participating authorities, especially Makkah Health Clusters, King Faisal Specialist Hospital, the Saudi Red Crescent, the Ministry of Health, and all my colleagues and doctors who participated or who were there, present there. So thank you all, and the floor is yours, Doctor.
Thank you, Dr. Ahmed. That was a very interesting and nice experience that was done. And I think it is probably the first time that mobile stroke unit is deployed during mass gathering and in field setting. And I would like again to thank the people that they participate again in the mobile stroke unit. I know they volunteers their time. You volunteer with them, Ahmed. They take 12-hour shifts during that mass gathering in Hajj, and that was really yeah, a significant approach, and there was very strong repercussions of that experience in the Ministry of Health and in other ministerial higher authority. And hopefully we would see this again in this Hajj season and in Umrah season as well, because of the benefit that they truly see and they truly experience. Thank you, Ahmed, for what you shared on your presentation. That was very nice experience. So let's now open the floor for questions. We invite our speakers to turn their cameras on and join us for this Q&A and discussion sessions. So do we have any questions in the panel, or anyone raise his hand?
Ahmed and Fahad, maybe I could ask a quick question. So, mashallah, congratulations on the amazing work with the Hajj experience. I just wonder, in terms of, you had one mobile stroke unit there. Did you find that that was sufficient with the large number of pilgrims, or was there, would multiple units be necessary to really fully cover everything that you need in that scenario?
Yes, for the mobile stroke unit, actually, I think multiple points need to be considered and audits need to be reviewed. However, we think that if we focused more on streamlining the stroke care pathways and also to raise awareness regarding the existence of mobile stroke unit in the first place, and also a streamlining approach and for all stroke patients to be presented, or for the mobile stroke unit to take charge of every stroke patient, I think that will be enough. However, also I think the positioning of the mobile stroke unit will place a very important role. I'm not sure about the utility of multiple stroke unit. Maybe Dr. Fahad may answer you better, but I think for the purpose of Hajj, mobile stroke unit provide the opportunity to move along with the pilgrims. So I'm not sure, Dr. Fahad, if you have any other insights.
I think I would agree with you, Ahmed, but I think what we need to do is to raise an awareness within the medical system itself, because the patient is always the patient. They will present with the symptoms. But I think streamlining the process, maintaining the ecosystem to understand that. And what we want to do is what Zishan alluded to, is a maximum utilization of the unit, so we can hit that mark where we are clinically helpful, however, economically effective.
As Dr. Shazam, so in Hajj, you know, the pilgrims, they moved from one place to another place. All of them, they moved together. So they will be concentrated people in one place, and then at that place, it's better to be served. I think that there was one region Dr. Ahmed mentioned, which is Mina. They stayed 3 nights in Mina after the Arafat. And in Mina, there are around 4 MOH hospital, which 3 of them, they have CT scan and they have telestroke as well, communication. But one hospital, which is in the middle of the valley, is they don't have, unfortunately, a CT scan, which is positioning the mobile stroke unit in that place would benefit pilgrims more because of the high flow to the hospital.
You know what? While we are waiting for the questions, Fred, I want to take your opinion about what is the best approach for the operation of the mobile stroke unit in terms of timing and the number of hours. So what's your take on that? What is the best model and how we should evaluate it if we are starting mobile stroke unit program?
So I guess, thank you for the question. I guess that would really depend on, first what your resources are and what you're able to do, so, are you able to staff a mobile stroke unit 24 hours a day, 7 days a week, and cover all times, or, are you going to be more limited to 12 hours half the day or certain days of the week? And then if you are going to be limited and you can't staff that unit all the time, then it would be looking at either, if you have the ability to go look at for the EMS agency, you can look at your local EMS and what type of calls they're getting during what portions of the day. But what might be actually easier is just to look at your hospital, and look at when patients are presenting, to the emergency department and when they're presenting with symptoms of stroke, and then try to generate some data, sort of like what we had, where you can see that the bulk of patients, for example, on our end, that were presenting to our emergency departments with stroke or stroke-like symptoms were coming between 8 a.m. and 8 p.m. We knew that we only had 12 hours a day that we could staff, and so then we tried to fit that in as best as we could to that time frame.
Thank you for that. Let me again, I have a questions for you as well. So I think you alluded in your presentation that the other EMS organization, the initial deployment of the mobile stroke unit, there was a fear that you may steal their patients. So can you just give us more of the discussion that goes between you and those organizations, how you manage that conflict and how you would you finalize that conflict?
Thank you. And so the first step was to try to win them over before we even started the mobile stroke unit, because there was a lot of opposition, and Cleveland's a little bit different. I mean, it's similar in a lot of bigger cities in the United States in that a lot of them, they belong to unions, and so unions, the union itself, raised some concerns that we were going to try to take away their business and then they would be out of a job. And so, and as Dr. Hussein will remember, we went to a lot of meetings, a lot of their EMS staff meetings, and we spent a lot of time with their leadership and with the EMS providers, that showed up to those meetings that were really the ground level caregivers. And, we did lots of presentations, lots of discussions, to try to show them that, we were really about making things better for patients. We weren't about trying to steal patients from them or steal patients and bring them just into Cleveland Clinic. And then the other critical step of that was developing the workflows, showing where the patients would go, because the other part of that opposition, it wasn't only that they thought that we were going to steal their jobs, but it was also that they thought that we were more interested in driving business into our own health system. And we didn't, so we were going to take patients and bring them to us no matter where they should have gone. And so we developed the workflows, to show them how we would determine where patients were going, and we shared that with them. So being very transparent was a key part of that strategy. And then once the relationship was built and we started operations, then it was giving them constant feedback, so they could see what we were doing and where people were going. And so they could see that the things that we promised and that we told them would happen were happening, and so that's how we went about it. I hope that it helps answer the question.
Yeah, thank you. That was great.
Dr. Khwaja, can I ask a question? In a low and middle income country, do you think that utilizing the unit as heart and brain unit can bring you closer for being cost effective and justifying the price for such a unit?
Yeah, I think it's a great question. Again, they're expensive, but if you're in an area, there's things to take into consideration, right? Is this a one-payer system? Is this an insurance-based system? If they care about the total episode, the total cost of stroke in terms of the rehab, meaning paying for all the rehab, paying for the nursing home, paying for the benefits if a patient is not able to work, then I think that there's a very strong argument, because there's a very clear correlation between, again, treating patients quicker and having less disability. The other thing is the volume, right? So as Dr. Husty said, I mean, one of the things that we did is we looked at our EMS call volume, right? So we looked to see how many times was EMS activated, for strokes. And then you could map that out and say, okay, if I have a unit, then we'll be called X number of times. You could make some estimations based on, we're going to be on a call, we'll be out of service during this time. And so I think, for low income, areas, I think, again, it's an individual, you have to take a very close individual look at your population, and it's beyond money, because I think if you're looking purely at money, there's an upfront investment, but you can reap. You saw that cost benefit ratio can be almost 7, which is almost a 7 times societal benefit, for every dollar spent on the MSU. So I think there could be tremendous value to mobile stroke units, as long as the environment that you're serving or the community you're serving has that need and there's sufficient volume.
And if Saeed allow me, I have a question that I want the take from Shaz and Fred. If we have multiple mobile stroke units in the city, what do you see the ideal scenario? How do they interact with each other?
Go ahead, Fred. I'm sorry, was that a question for that's a question for Shazam?
No, I need both take. I need the director of the stroke point of view and the director of the EMS point of view.
Okay, Shazam, I'll defer to you to go first.
Yeah, I guess I could talk in general. I mean, I guess it depends a little bit on everything. Everything's local here when it comes to these mobile stroke units. So if we're talking about just in general, the data that we have around a mobile stroke unit and covering a population is that one truck probably covers about 500 to 600,000 patient lives. So obviously that depends on population density, geography, other factors like that. But that's generally where the numbers, no matter how you do the analysis, it comes out that one truck can cover about 500 to 600,000 people. So, like here in the city of Cleveland, for example, if we ideally wanted to cover the whole city, I would get 3 trucks, one positioned east, one west, one south, so that they, again, like the Berlin map I showed you guys, it overlaps in the middle. And then you likely, it's nice that we have an older truck, we keep that one reserved just because, you know, trucks need their maintenance, right? So they need to get, the truck or the scanner needs maintenance. That way you're never really out of service. So the bigger challenge comes in when you talk about, you know, if multiple systems have mobile stroke units, and then how do those interact? And that becomes, again, a bigger issue of just the general politics. You know, and it depends on the city. Here in Cleveland, we were lucky that Cleveland, at least the city of Cleveland, has one EMS provider for the whole city. If you talk about the greater Cleveland area, I know, Fred, correct me if I'm wrong, it's something like 48 different EMS providers. And so you can imagine if 48, you know, providers have a mobile stroke unit each, it's a very, very difficult thing to how do you coordinate. And then there becomes boundaries of, you know, their jurisdiction from their municipality and these kind of things, or how you can combine those. So, you know, again, I would say one truck for 500,000 patients is a good number, but there's so much politics that goes into this at a local level. So, Fred, you could probably comment on that a little better than me. So.
Yeah, no, I mean, I think that was, I mean, that pretty much covered it. You know, one of the challenges, I think, you know, in an environment that we operate in, as Shazam alluded to, is that, you know, every EMS agency has a medical director, and that medical director is affiliated with a health system somewhere. You know, so, you know, for example, there are EMS agencies that we would like to work with, but because their medical director for that agency works for another health system, you know, they may not be very receptive to this program, you know, because it's a Cleveland Clinic program, and it's, you know, the health system happens to be a competitor of Cleveland Clinic. And so, you know, we would really like to be able to expand to all the areas that we could cover to help as many people as we can help. But unfortunately, that has been an obstacle here, you know, I mean, we've got municipalities that are literally, what, Shazam, maybe like 10 minutes down the road from where the mobile stroke unit is, but yet we still don't have access to that population because the medical director is affiliated with, you know, a competing facility. So, you know, that's one of the challenges with the landscape, as Shazam alluded to. You know, it's very politically complex to navigate.
Mm-hmm.
Allow Ahmed to skip you to answer this part, but the rest of the panelists, what's your comment about using the MSU in a mass gathering with all of its restriction? For example, the Olympics, the World Cup, which is coming to the United States very soon. You know, such mass gathering when all of the restriction and that. What's your take on that? I would like to hear from all the panels.
Zishan, you want to start off?
Yeah, I mean, can you, Dr. Fahd, can you explain when you say restrictions? What do you mean by that?
I mean the mobility, having the
Yeah.
traffic without crowdness that is always available.
Yeah, no, I mean, to be honest with you, I think the advantage of the truck is getting the treatment at the doorstep. And so a place like the Olympics, I'll give you an example. You know, when we had the presidential debate here in Cleveland some years ago, we had even though the hospital was right across the street, we still had the mobile stroke unit there. When we have big events, the mobile stroke unit, you know, makes themselves available. And so I think that's the key driver. We know that we save time, we save brain using the mobile stroke unit. So having it in a place where it'll take a long time to get that patient treated can be the difference between being functionally independent or being severely disabled. So I would be very much in favor in, you know, using these mobile stroke units at the Olympics, for Hajj, you know, for Umrah, for, you know, places where mobility is very, very tough.
No, I like what you guys did there for the Hajj, because my understanding is that they get treated, like you have the CT scanner, you treat them, but then transportation you don't necessarily do with the mobile stroke truck, correct? It's a different vehicle that takes them. So I think that ability to take a program, essentially, you're taking the CT scanner and the stroke expertise. I mean, it's very similar to the concept we use mobile stroke about how do we take to patients' homes, but you can then put it in an area where you, as you said, you have that difficult situation when there's many people, and we know that getting in and out of those areas becomes very, very challenging. Having that mobile stroke unit there, being able to you know, provide that expertise, you know, via, you know, physically the presence of the CT scanner, potentially those individuals being there, or even potential use of telemedicine. I think telemedicine also makes this very, very valuable. That it's an opportunity to make sure that those gatherings have the proper coverage that they'll need for adequate medical care. And that, to your point, I think you were making a point about that, is that besides just the stroke situation, are there other situations then that mobile stroke unit could handle? I like the way Ahmed put it together, that it's really a mobile neurological care unit, and can that be beneficial not only for stroke but to other conditions as well? Yeah, so maybe the World Cup we can see Zishan wants to go to some games, so we'll see if we can get the mobile stroke deployed maybe. So
Fred, any take on this?
I mean, I think, first of all, I thought that presentation by Dr. Al-Khoury was very impressive, and how that worked. And I was really, I mean, as Shazam said, I was really struck by the fact that the mobile stroke unit, does what it's meant to do, and then, the patient's handed off. Because I saw, when you gave the presentation, I saw, and I might not have the numbers exactly right, but you had something like 6 cases within a 2-hour period, that were there, or something like that. Is that right, I think?
Yeah, it's more like we treated patients, we improved our system by almost 1 hour and 15 minutes delay in the hospital, within the hospital. So prior time were 1.5 hours, and door to needle times and our times were only 15 minutes.
Yeah, it's very, very impressive. And here in the States, we, the way the rules and regulations are, it would be very difficult to be able to take advantage of a program where, the patient came into the stroke truck, when we showed up with EMS, we did the thrombolysis, and then we handed the patient back off to EMS so that we could be in service again and serve more people. But, you're able to do that. So, I mean, it's congratulations.
Okay, since we passed the time, I think we want to thank all the organizers, and I'll pass the mic to Said.
Yeah, thank you all for being here with us today. It has been truly informative session, and we appreciate your participation and engagement. I would like to inform everyone who attend this meeting, there will be a for this webinar sent to you in the next week. Once you have completed and submitted the form, you will receive your CMA certificates. Thank you again.
Thanks so much.
Thank you. Thank you so much for inviting us.
Thank
Yeah,
you.
great
Pleasure, Fred.
to have you all. Thank you very much.
Thanks so much.